I love my mornings when I know I'm going to the office and I'm going to be able to do a digital platform CAD/CAM procedure, particularly with the Primescan. I've been doing this for a long time, over 15 years, started with the Red Cam. The Primescan just flows. It's just a dream. I never thought this would be at this point within my career. And it gets better and better every day. I love going to work with my sidekick, Jordan. He's with me every day. He hangs out back in the office, but he loves to get his vest on. He knows he's going to go and have a day at the office, and he'd rather go to the office than stay at home. Today, I want to walk through the flow with the Primescan in my clinical theater on how to make this flow go well and be very proficient. We have a lot of great materials we can use today. I primarily use lithium disilicate and zirconia. I still like the microfelspathic and the lucite blocks, and there's new ceramics entering the market that are really exciting. But to know the fact that regardless of what I'm going to do, whether I'm doing a digital study model, a workup for orthodontics, a workup for full mouth, or just a quadrant of good dentistry, the Primescan has made this such a seamless flow. Particularly, I have these issues with really good margins, right? That was drilled into us back in dental school, and I'm OCD on margins. One thing I like about the Prime is that I can see the margins so well on the scan. There's no guessing anymore. I know I'm gonna nail it, and I'm gonna sleep better at night. So we're gonna go ahead and go to the office. It always starts with your pre-records. So we're going to go through the pre-records, which would be your bite registration, which is critical to not having adjust occlusion later on. So my big deal there is seat the patient up, have them tap a dozen times to make sure all their periodontal ligaments are seated in the mouth. That can make a difference. PDLs move around 30 to 90 microns based on who your patient is. So you want to seat those PDLs because that's where they go when you adjust the final bite if you have to. Now my goal is not to have to adjust the final bite. So I'm going to seat the patient up and we're going to go ahead and have the patient tap 12 times. I will often place my hand on their jaw just to get that vibration sense. I use my tactile sense and also the audio quite often. So tap, tap. You want the bite to sound good, right? Well, I want to feel the bite in the lower jaw, and then I'm going to take my buccal scan. Prior to the buccal scan, make sure you have the patient bite firmly. I don't usually use the word clench. I just have them bite firmly, number one, and then make sure they hold it until we're done with the scan. So let the patient know I'm going to have you bite firmly about 4 to 5 seconds, and I'll let you know when to release your bite. And in that case, we're going to go from the distal tooth in the quadrant to the canine. Don't wrap it around anteriorly, you don't need to do that, and that would be for a quadrant bite. Now, if you need it for a full arch bite, you do it the same way. Go ahead and take the scan on your first side. Make sure your upper and lower models mount first. You'll see that in the acquisition screen. Then go to the other side, do the same scan in the premolar, molar area, including 3 to 4 millimeters of the attached tissue. That is going to mount your models extremely well. When possible, it's always better to get the buccal scan before anesthetic because it can throw off those muscles, right? And take it before we're stretching the patient like a crocodile, particularly if we're using the isolite. I don't use that many inferior alveolar blocks now. We have on Pharma, we have the ability to create a bicarbonate mix within our anesthetic. I use articaine. Even for second molars, I'm using articaine buccal infiltration with profound anesthetic. I'll go ahead and look at the CBCT, look at the buccal cortical plate. If it's not really thick, even in a second molar, we're going to see profound anesthetic even on a second molar. And if we need a little more assistance, we'll do a PDL. I use the comfort syringe. I use it for me. It's really easy to use and it lowers my stress and the patients as well. Sometimes we can't take the pre-existing buccal scan if we're doing a quadrant. We have to do it later on, and there's a sequence for that. We can still set the patient up, make sure we seat the condyles because they will sublux with wide opening, right? So we want those seated, and we're always going to verify that in the model screen, right? Once your models mount, make sure you go into that model screen where the models mount and open up the contacts, view the contacts, make sure your models are together. That way you can trust your bite. I very rarely have to adjust my bite, and taking that buccal scan right is one of the first things we do to make sure it works. And there's a few other tips that are critical that I'll share later on in this video to make sure we don't have to adjust that occlusion once we seat our restoration. That's why I like CEREC and particularly Primescan so much. I've done a number of prospective events with Primescan. One of the comments I get particularly from prior Omnicam users is that the camera tip is so big. Well, it's really not a problem. I just did this on a client the other day where they were concerned because they have a small mouth, smaller than mine, and they have a gag reflex. And it was a dentist, so I went ahead and demonstrated how easy it is to use the Primescan. Particularly the size of the Primescan allows you to use the back side of that camera as a cheek and tongue retractor. The way we're going to scan either a quadrant or a full mouth is to use the camera over the occlusal table in the premolar to start the streaming. Then we're going to move it and slightly rotate it to the buccal on the upper arch to get that buccal corridor. That movement will retract the cheek out of the way, and if they have a smaller mouth, just have them slightly close as you move that camera to the buccal, and you'll proficiently scan the buccal corridor. Proceed forward in the quadrant to the midline if they're vertical chewer, to the opposite canine or premolar if they're horizontal chewers. Complete the scan by gathering the lingual data. That is my preferred scanning for quadrants. And now we're ready to scan the lower arch. You can either scan the upper or lower arch first, it doesn't matter. We're doing this while the anesthetic is taking effect. I usually give patients 5 to 8 minutes for anesthetic. That way when I'm prepping, I'm not worried or concerned about them feeling anything. For the lower arch, we'll use a similar technique. We'll take the Primescan over the premolars, allow the streaming to begin, and then slightly rotate it to the lingual, letting the back side of that camera move the tongue out of place. Once you have that information, scan forward to the midline or the opposite premolar, and then complete the buccal information as you need it. It's really so easy. That's where Primescan is easier to scan than with Omnicam for those that have used Omnicam, because that's a smaller tip, but you have to move the camera a lot more. In most cases, to acquire the buccal information, we just rotate the camera about 45 degrees from that occlusal table, and it will gather all that buccal or lingual surface with good undercut data. Unless they have abfractions, sometimes we have to move it clear to the buccal, but in most cases we don't. It's so proficient. One nice feature over the last few versions of the software is the auto cutout feature. Now in the past, what we do in the acquisition screen is that we'd cut out the tooth, right? That we're going to prepare, and then we're going to go ahead and scan over that once the preparation happens, and we'll get that preparation and the proximal contacts on the adjacent teeth. Now, at this point in time with the Primescan with the software, it will proficiently do the auto cutout for you. So all you do is start scanning over the molar area, start to stream, and then place that camera over the prep, and you'll see the prior tooth evaporate prior to prepping, and it will gather the new data. Scan the buccal, lingual, pitch for the interproximal, and quite often on the molar distal to the prep. We'll take the camera 90 degrees and move it sideways so we can rotate that camera lens. It will effectively gather that interproximal information on the tooth distal to the prep, and that's how you make it work. Another thing I love about Primescan, and we should do this all the time, is always record a pre-existing catalog prior to prepping, right? Most of the time, posteriorly, I'm using biogeneric individual for my proposal. However, we still turn on a biocopy catalog. And once you scan the quadrant that you're doing the prep in, just copy it over to that biocopy catalog, and we'll have that pre-existing condition prior to prepping. Later on in the design of the case, particularly with biogeneric individual, we can use that pre-existing condition in display objects and turn it on 50%, and it will guide you, particularly on the upper buccal corridors and the height of those cusps, if we want to reproduce that buccal corridor that the patient had prior to prepping. And when you're doing a quadrant, sometimes it's easy to lose your references. So always have a pre-existing condition of that arch before you ever start prepping.